Good afternoon. I'm Momon. I'm an associate consultant from Urology from Kutipot Hospital. Thank you for attending this session on medical legal issues surrounding informed consent. We are honored to have an expert lawyer, Mr. Christopher Chong, here with us today. He is a senior partner in Denton's Roddick's Litigation and Dispute Resolution and Arbitration Practice Groups and co-head of the Professional Liability, Healthcare Practice and the Insurance Practice. His main areas of practice include professional malpractice, commercial litigation and insurance. He has defended hospitals and medical practitioners in medical negligence suits in both the High Court and the State Courts. Chong, please. And we are also very grateful to have Dr. Toh Kai Lee and Dr. Molly Ng here to share their clinical experience and insights on this tricky topic. Dr. Toh is a renowned senior urologist with his own private practice. Previously, he was head of Department of Urology in Tan Tock Seng Hospital, and he was also a former president of the Singapore Urological Association. He's well-recognized for his expertise in reconstructive urosurgery and is often an invited speaker in many conferences, both locally and overseas. Dr. Molly Ng is originally from Malaysia and trained in Ireland, specializing in transplant surgery before returning to this part of the world to be closer to home. She is currently senior consultant and head of urology at Kutipot Hospital. Besides transplant work, she also has special interest in endourology, minimally invasive surgery, and uro-oncology. So today's topic on medical legal issues surrounding urologists is a very relevant topic for our day-to-day practice. As surgeons, we face many challenges in preparing the patients for various surgical interventions and in particular in counseling the patients regarding the risks involved as well as addressing their specific concerns. Especially in this day and age of individualized medicine with increasing need to respect patients' autonomy and wishes, we are therefore at an increased exposure to litigation. To lay the grounds for today's discussion, let me present to you a case scenario for a routine, seemingly straightforward operation and the medical legal implications that arose from this case. First, a disclaimer, this is a hypothetical situation and not a true story. We have a patient, Miss LML. She's a 45 years old teacher. She has a past medical history of right distal ureteric stone, for which she has undergone ureteroscopy and laser lithotripsy many years ago in another hospital. So now she presents to general surgery clinic with non-specific abdominal bloatedness. A CT abdomen and pelvis show essentially a single functioning kidney with a Steckhorn stones within the kidney. So she was referred to urology, and at urology clinic, she was seen by senior resident Dr. A. At the clinic itself, her symptoms have resolved. She no longer has any pain, no urinary symptoms as well. This is her CT scan. You can see that the right kidney is thin out, hydronephrotic, and on the left side with the functioning kidney, there is a Steckhorn stone. This is the clinic consult notes as documented by Dr. A. So he correctly counsel her for treatment of the left-sided stones. He explained to her that her kidney on the right side is impaired. She will need treatment for the stones on the left side, otherwise the stones can progress, cause pain, infection, and eventually cause renal impairment and may lead to dialysis. So he offered her PCNL and counsel her as per standard counseling for PCNL, which includes general anesthetic risk as well as risk of operation, including bleeding that may require additional procedure to stop the bleeding, infection, failure of access, failure to clear the stones, as well as injury to surrounding organs. And he explained to her that this is the best chance of clearing the stone as a single-stage procedure. He also offered her alternative of retrograde intrarenal surgery. And in the end, the patient decided on PCNL. What was not documented but transpired during the clinic consult, so Ms. LML asked Dr. A, now I'm pain-free, can I leave the stones alone? So Dr. A reiterated to her the risk of not treating the left-sided stones, in particular, potential need for lifelong dialysis if the kidney runs into trouble. So then the patient says, dialysis, oh, very scary, I better go for surgery then. So luckily for her, she got an OT slot within 2 weeks. On the day of the operation, the consultant in charge, Dr. B, and another senior resident rostered to the OT, reviewed the patient at OT reception. During the site marking, they briefly spoke to the patient, asked her if she has any last question, but we did not retake the consent because the consent is already taken and valid, and patient did not have any further questions. So no formal documentation was made of this pre-op encounter. So operation was performed by Dr. C, who is a senior resident, under supervision of consultant B. It was seemingly uneventful. Unfortunately, post-op patient has significant bleeding requiring angioembolization. So when she underwent angioembolization, consent was retaken. Post-angioembolization, she went into renal failure requiring ICU admission and dialysis. Eventually, she did recover. She weaned off dialysis, but on discharge, creatinine was 208. Now we have a very angry patient who wants to sue the hospital as well as the surgeons for failure to counsel her adequately about operation and its risk. And she wants compensation for post-op complications as long as the long-term renal impairment. And she wants to know if the complication occur because of incompetence of the trainee surgeon. So we have a few questions as to who is responsible, who can the patient sue, what is adequate counseling, and how much do we need to tell the patient. And things that are not routinely problematic, not a common complication, how much do we need to tell them? And also, do we tell them just potential complications or treatment of these potential complications? So with these questions in mind, let us now invite Mr. Chong to share with us an overview of legal proceedings in Singapore and where the Singapore law stands with regards to informed consent, and allow him to go through some of these questions. Mr. Chong, please.
Thanks, Mohan. Give me 1 minute while I try and find my slides. Okay, so thank you all for inviting me for this session. It's always nice to talk to doctors about something that's within my expertise rather than your own. Okay, well, obviously when I go and see doctors, they all will tell me what to do, right, as far as my treatment is concerned. So what I'm going to do firstly is that instead of jumping straight into consent taking as an subject, I want to kind of take a step back and take a helicopter view. I'll explain to you why the issue of consent taking comes up. And this is the first slide says, we talk about legal proceedings. And then I also want to talk about where consent taking comes in when we talk about medical treatment. Okay? And I think there are certain words that we hear about before, standard of care, BOLEM. So I will do what I'll call a quick revision on this as well before we jump into what the latest developments are for consent taking. Okay, so this may overrun a little bit. So firstly, of course, when you talk about consent taking and based on the scenario that Mohan has given, this all relates back to when something goes wrong, what does a patient do? The patient will go and look for lawyers and consider starting legal proceedings. So legal proceedings as a term is where somebody decides to sue a doctor in court because something has gone wrong. Okay, and in Singapore context, the only thing a patient can sue for is money. Okay, the patient cannot sue for anything else like, oh, I want my kidney back or things like that, or even, oh, I want so and so to do another treatment for me. When it comes to, let's say, oh, I want another treatment, it will be the money that will be incurred for that other treatment. So it's all about money when it comes to legal proceedings in the Singapore courts. Now, the other thing to bear in mind about legal proceedings for medical malpractice cases is that the law until a few days ago was all developed by the courts. Now, the law in Singapore and most other countries has got two sources actually. One, Acts of Parliament. So for example, revenue law. All of us have to pay income tax, right? What is the basis for us having to pay income tax? How do you determine assessments? All these things are based on the Act of Parliament, the Income Tax Act. Okay? Sure, the courts may need to interpret how some of the provisions in that act are to be applied, because when people draft a document, sometimes they don't think very far ahead as to, oh, if I phrase it this way, later on someone can come and argue and say that actually the effect is A rather than what I intended B. So yes, so certain times when we talk about Acts of Parliament, the courts will come in to try to interpret what Parliament actually meant. But otherwise, that is one source of law. Another source of law, which is very pertinent for these kind of medical malpractice cases is court judge-made law. Okay, so through the years, for medical malpractice, for what's called negligence law, it's always been judge-made law. Okay, so one of the first questions was, when a patient goes to see a lawyer, right? So the first question is always, hey, who can I sue? Okay, who's at fault? So I think we had 3 scenarios here, right? And so who can be sued? So why can people go after a doctor? Simply because the doctor himself has certain shortcomings in the treatment he provided to the patient. I define treatment later on. Apart from doctors, very often the lawyers will also advise the patient that, hey, maybe you want to go after the institution itself. Why? Because the institution is responsible for staffing nurses, right? The institution is responsible for processes. The institution is responsible for, let's say, the equipment as well, surgical equipment. All these things all fall under the remit of the institution, okay, the hospital. So, under that kind of a scenario, a lawyer may try and find some interesting ways to say that, hey, the hospital is at fault as well. Okay, and then go after the hospital. Now, the third bullet point I put here, it applies mainly to the restructured hospitals. Vicarious liability, what is this? This is where an employer, in this case the hospital, can be sued for the wrongdoing or shortcomings of its employees. So in the restructured hospital scenario, the restructured hospital is legally responsible for the actions of its doctors as well. Compared to private sector, let's say Mount E, all doctors there are considered private, what you call independent contractors. So in that kind of scenario, normally lawyers do not sue the Mount E for the actions of the doctors. Of course, we also have nurses. So nurses are usually covered by vicarious liability owed by the hospital as well. Now, why is this important? It's just to set out that when it comes to cover, I think all doctors need to have their own insurance cover, right? So for those in private practice, you have your own insurance cover. For those in restructured practice, you will be covered by your institutional, I think what's called MMI. Okay. So just as I mentioned, I will break up medical treatment. Now this is what lawyers do. We try to compartmentalize things so it's easier for us to understand. So when we talk about medical treatment, we try to break it down, and the courts have actually broken it down into 3 kind of distinct areas. 1, diagnosis. So any allegations that a patient's lawyer may make may be about the diagnostic steps that were taken, whether the diagnosis was wrong, whether other tests should have been carried out in order to arrive at a certain diagnosis. Another aspect, which is what we're talking about today, is about advice. What was the patient advised? In scenarios like this, I'll cover the information that should be given. So it goes, when we talk about advice, it goes beyond just taking of consent, which I think we all think is, nature, purpose, risks, and complications of a procedure. Right? That's what we always think about. But advice is a bit larger than that, a bit wider than that, and I'll cover that a bit later on. So then the third aspect that we courts deal with is about the actual treatment that's carried out. Okay? So, and I think you all understand what that is. So what happens in a normal situation where a patient goes to see a lawyer? The lawyers usually will throw the kitchen sink at everybody, right? They will not necessarily make a hard call to say, you can only sue so and so. You can only sue so and so. In reality, they try and sue everybody. And they also make allegations about diagnosis, advice, and treatment, what I call the kitchen sink approach. Okay, because very often the lawyers are not necessarily in a position at that stage to decide where responsibility should fall, where there's been a complication arising from treatment. Okay, so in our situation, who can a patient successfully sue? Dr. A will consult the patient, Dr. B is consultant in charge, Dr. C who performed the procedure. So, of course, the patient will want to sue Dr. A because he will say that the information provided to him, the consent-taking process was inadequate. Okay, so very clearly, the lawyer will go after Dr. A. consultant in charge. Now, this one is of course a little bit more controversial. As a patient's lawyer, he will definitely be sued. Okay, as I said, kitchen sink. All right, his name is there. He must be part of the team. I want to go after him. And he's a consultant in charge, right? So captain of the ship kind of theory. Now, in real life, just because your name is there in the medical records doesn't mean you owe any legal liability, legal responsibility. It all comes down to what is your role. If, let's say, you have a supervisory role, let's say, for example, your junior is doing the procedure, was it necessary for you to oversee? Was it necessary for you to be present? Should you have been present during the consultations? Things like that. Or sometimes, I think in teaching hospitals, did you even teach your people properly? All right, so you need to look at those kind of angles to see whether the consultant in charge can be legally responsible. If at the end of the day, Dr. B's name is there just for record purposes, then even though it's going to be sued eventually, but the likelihood of a successful lawsuit is fairly remote. Okay. Then third one, Dr. C, the one who performed the procedure. Of course, he will probably be sued. But what we try to do is, when we talk about A, B, C, is A is about the advice given. Dr. C is about the treatment. Okay, whereas Dr. B is about everything lah. All right. So again, the example we give you about Dr. A, Dr. B, Dr. C is to try and split up the three different aspects of medical treatment. Okay, where we talk about diagnosis, advice, and treatment. Okay, so just moving on quickly. I think you all know about this. When you go to court, you need to show duty of care, standard of care, and loss caused by that breach of duty of care. Okay, so bullet point 1, bullet point 3 are legal arguments. But bullet point 2, standard of care, is relevant for all of us here, and particularly relevant when we talk about consent taking. Okay, so coming back to this, now, I think all of you have heard about Bolum and Bolito, right? So, in Singapore context, when we decide whether or not the standard of care has been met for diagnosis, for advice, and treatment, we have always applied the Bolum and Bolito addendum. And these are the Bolum test. This is a 19th century case from England, which he went on to apply in Singapore. So, judge made law. Okay? Very simply put, is that as long as a defendant doctor can produce a supporting expert opinion, and preferably from a responsible body of doctors, then the judge must accept that opinion and accept that the doctor was not there was no shortcoming in the treatment provided to the patient. Okay, I'm just paraphrasing. You can see the wording here. Now, there was some pushback when Bolum first came out, because then it seemed to be a case where the moment, if I'm sued as a doctor, I go look for my friend. Hey, give me a supporting opinion. My friend gives me a supporting opinion, the judge has got no choice as to accept it, even if the patient has his own expert opinion criticizing my treatment. Okay, why do you have the Bolum test? It's because a judge is a lawyer. He's not medically trained at all. Right? He is not in a position to say whose opinion should be preferred, that of a patient's expert or that of a doctor's expert. Furthermore, the courts have held that, for some reason, medicine is more like an art rather than a science. Okay, and things are developing all the time. So there's not necessarily one way or the highway. All right, so in recognition of this, that's why the Bolum test came out. But you can see there's a problem. Because then clearly there is a risk that even where there are actual shortcomings, simply because I can find my own expert, supporting expert, I actually get away with it. So that's why we came with the Bolito addendum, which simply talks about how any expert opinion that you come up with needs to be logical. In other words, the judge doesn't have to just blindly accept it. He can examine your expert opinion to see whether or not it makes sense. Is it reasonable? Is it logical? If it is, then he'll accept it and then proceed to find that there's no liability on the part of the doctor. Okay, so in this particular situation that we have, was consent. Okay, so what we have to look at is consent taking. What is adequate and what is adequate counseling in the questions that was raised by Mon, right? So as I mentioned just now, advice is part of medical, the middle aspect of medical treatment. Why is it different from the other two? Strictly speaking, it is different because diagnosis and treatment are only involve the doctor. Okay, the doctor decides what tests to carry out. Based on those tests, the doctor decides what the diagnosis. Same thing for treatment, right? In the sense that after my diagnosis, I decide what treatment to carry out to the patient, and then I carry it out. Whether I carry out properly or not is a matter for medical opinion. So diagnosis, treatment, very much medical opinion issue. But should the Bolam test apply to issues of advice? Because advice, consent taking, involves the patient. The patient needs to consent to anything that you do to him. All right? So are we then correct to simply say, oh, even when we talk about advice, the doctors decide what the patient should be told? So there's been a fair bit of discussion as to whether it should be like that. Okay? Now, the last bullet point is there, kind of like standing out on its own, because I just wanted to also just tell you, when we talk about consent taking, advice, it is not a form-filling exercise, in the sense that when a patient says that there was inadequate consent, that consent, the advice given to the patient, doesn't necessarily have to be at the point in time the patient signs the consent form. So for example, Mount E, right, we have this consent to procedure form. Okay? And it says all risks, all nature, purpose, and risks of the procedure has been explained to the patient. Now, the advice doesn't have to be given at the time the form is signed. And it doesn't even necessarily have to be given by the doctor before whom the patient signs the form. Okay? The courts have recognized it as a process. So you might have a situation whereby, a little bit like here, where you can have another doctor giving the advice who is different from the proceduralist. That consent is still valid, provided, of course, that's appropriate. Okay, so it's something for you to bear in mind. Consent taking is not a one-off thing. You don't look at it at the snapshot in time. It is a process. Okay, and the court will consider the entire process in determining whether the patient had proper advice. Okay, this one I think all of you should know. When we talk about advice, what does a patient need to know? Obviously the diagnosis, right? Prognosis, nature of the proposed treatment, of course the risks of the proposed treatment, as well as the reasonable alternatives to the proposed medical treatment and the advantages and risks of those alternatives. Okay, I think this is all fairly standard, and this would all apply even when in the Bolam test is applied. Okay, now, so when Bolam and Bolito was there, and we dealt with the issue and looking at whether or not there's any breach of liability as far as advice is concerned, there was a lot of pushback, particularly back in the early 90s, because there was an Australian case where it appeared very, very clearly that it was illogical to apply Bolam. Now, in that case, female patient, blind in her right eye, I think, okay with the left eye. Then when she went to see an ophthalmologist, she was advised to undergo treatment to the blind eye, removal of scar tissue, things like that, for appearance purposes. Okay, I'm simplifying a little bit. Now, there is this complication which is called sympathetic ophthalmia, where there is a low risk that the procedure that's done to the right eye can actually cause can actually affect the left eye, the good eye. Okay, but the risk is very low. So unfortunately, Murphy's Law, the risk occurred for this patient. So procedure done to the unsighted eye, complication occurred to the left eye, and so the patient went blind. She was not told of the risk of sympathetic ophthalmia. Okay? So when she sued the ophthalmologist ran the defense of the Bolam test. He could produce a number of doctors who say it is not the standard practice to advise a patient of sympathetic ophthalmia because the risk is so low. Okay? And if the Bolam test was applied by the Australian courts, then the doctor is free, right? No liability. Even though I think logically most of us will wonder, yeah, but doesn't the doctor know that for this particular case, for this particular patient, he should have gone beyond just looking at what I call a cookie cutter patient, okay, and advise further. So for that case, the High Court of Australia decided not to apply Bolam and said, no, you need to look at the particular patient in front of you and your advice needs to be based on that particular patient. So that's early 1992, I think, that case. All the other Commonwealth jurisdictions followed that case, except the UK and Singapore. Malaysia went along and followed that case. Canada did the same thing. The only standout was in Singapore until 2017. Okay? When our Court of Appeal said that in determining whether or not a doctor has met the standard of care as far as whether the advice given was appropriate, you need to look at what information is relevant and material to the reasonable patient. Now I pause there. What does this mean? It means that you look at your standard patient first. Okay? So that's the first step you need to do. Standard patient, for this particular procedure, what would you usually tell? Okay? Then, the second thing, you also need to give information which the doctor knows or ought reasonably to have known is important to that particular patient. So you move away from your standard patient and you must then consider that you're the one sitting in front of you. What is the information that he will need to know? And only if you have satisfied both, then you have satisfied the standard of care as far as the giving of advice is concerned. So, the part which I think a lot of doctors and even us lawyers had a bit of an issue with was that this test, okay, appeared to be only determined by the courts. Okay? That means the court decides what is reasonable for a patient to know, what the patient ought to have known, without the benefit of the Bolam test. Okay? Remember, all along doctors had this kind of a security blanket, right? To say, oh, even if I get sued, I can look to the Bolam test for support. But I think you can see that to some extent, it makes sense to talk about particular specific patients rather than to ignore specific conditions or specific concerns of patients. Okay? So, just a couple of weeks ago, the law on this was actually changed. And it was changed by an Act of Parliament. Okay? So, right at the start, I talked to you about judge-made law as well, Acts of Parliament, right? So, our Ministry of Health felt strongly enough, after hearing all of you complain about it, they went on to change the law on this by inserting Section 37 of the Civil Law Act. Okay. So, this diagram here shows to you the law on the standard of care. Okay, the law for determining standard of care for diagnosis and treatment doesn't change. It's the Bolam Bolito. But the law on the standard of care for advice has changed, pursuant to Section 37 of the Civil Law Act. What the ministry has done is to bring back a form of the Bolam test. Okay? But they don't call it Bolam test anymore because obviously Court of Appeal had said this doesn't apply, right? So you cannot call it that anymore. So what they call it is pure professional opinion. But if you look at it, it's a Bolam test. Okay? Standard of disclosure is to be determined by a pure professional, and that pure professional opinion must be logical. So isn't a pure professional the Bolam test? A logical pure professional opinion, that's a Bolito addendum. Okay, so maybe not through the back door, but through a side door, we have essentially brought back the idea that you still need to look at what the profession considers to be acceptable practice when somebody complains or claims against you on the basis that the advice was inadequate. Okay, I think that's important for you to bear in mind. Okay, then, but, caveat, bullet point number 2. You must also consider the information that a person in those same circumstances would reasonably require to make a decision. Okay? And this information that a professional knows or ought reasonably to know is material to the patient. So what has happened here? Sorry, I got this notice telling me it's time's up. I don't know how to delete that. Okay, so in recognition that the Bolam test and the Bolito addendum sometimes are not so relevant and doesn't capture everything as far as advice taking is concerned. Remember just now I spoke to you about involvement of patient, and also in recognition that patient autonomy is a lot more important in this day and age. We no longer have a situation where we are paternalistic about things. The doctor tells the patient what he should do and expect the patient to just follow instructions. Okay, this day and age, a lot more, you need patient involvement a lot more. Patients want to be involved in decision making. So in recognition of this, that's why you have bullet point number 2 and number 3, which is you need to look at that specific patient as well. Okay, but it comes back to your peer professional opinion still. Right? So Bolam, in a sense, is still there, provided you consider this particular patient. So let me take it even 2 steps further. Look at the Roger the Whittaker case I described to you just now, right? Where all the experts said, no, they wouldn't have standard of care. You don't tell patient about sympathetic ophthalmia, right? But now, if we apply the peer professional opinion to that case, okay, what the requirements here? What the expert doctors there would be asked will be, sure, you don't need to, it's not standard to tell about risk of sympathetic ophthalmia. But now you have a patient who's already blind in one eye. The treatment is to the blind eye. In this particular situation and circumstances, should the patient then have been told about sympathetic ophthalmia? Okay, so that's how the new Section 37 will be applied. You look at not just standard, but also patient-specific circumstances in determining what the standard of care will be. But again, standard of care will be determined, or at least there will be input from your peer professional expert opinions, and not just rely on the courts to decide what is acceptable or not. Okay? One of the points was about logic, right? So again, Section 37 puts in writing in the Civil Law Act what is already in the Bolito addendum. Okay? That the peer professional has directed his mind to the comparative risks and benefits relating to the matter. The opinion is internally consistent and does not contradict proven extrinsic facts relevant to the matter. Bolito test. Okay? Now, you may then wonder, okay, what information should a treating doctor, as well as eventually the professional who you engage to write a supporting expert opinion, what information is actually relevant? What information is actually material? Because I think for our purposes, of course, you don't want to have a lawsuit first, then after that, discuss what is relevant or material, right? At the time you're treating the patient, you want to be able to assess what a patient should be told. So this is what the Minister of Law said in Parliament, and I think it's also, this part is actually covered in the Civil Law Act as well. What information is material? Specific concerns or queries expressly communicated by the patient. I think that's quite obvious. Okay? Second thing, because sometimes it may not arise in the course of the discussion, concerns or queries that ought to be apparent for the medical records that ought reasonably to have been reviewed. You can see a lot ought, a lot of reasonable, right? Okay, that's just legal jargon, because there is not necessarily white or black. There are a lot of grey areas. So it's still up to parties to determine what is fair, what is reasonable. Okay, so bullet point number 2 deals with what's contained in the medical records. So, medical records. whether or not it's reasonable to review the medical records and information contained in there will depend on a few things. Okay? Number one, the age of the records. If the patient is seeing you today, but the medical records go back 10 years, do you need to look at records 10 years ago? No. The Minister of Law actually specifically said that. But of course, 10 years is kind of an extreme. That's why the Minister of Law said 10 years. Right? I think it's a lot more arguable when you talk about 1 year ago, 2 years ago, 3 years ago. Arguable. But again, it comes down to what's reasonable. And that's where your peer professional, your expert opinion is important to explain why, even though it's 2 years ago, it's not necessary to look at it. Or it's necessary to look at certain things. The other thing, apart from the age of the records, nature of the discussion. What was it like? Was it a off-the-cuff comment by the patient? Or was it something that the patient was very, very earnestly wanted to find out more, was concerned about? So for example, the Rogers and Whittaker case, right? If the patient had specifically asked, will it affect my good eye? That kind of discussion, I think most of us would accept as material information that the patient wants to know about. Okay? Whereas, let's say, for example, oh, will I be able to play a piano after that? Maybe that's not so relevant unless the patient is, let's say, a concert pianist. Okay, so the doctor needs to assess from the course of the discussion whether it's something that the patient wants to know about. Is it material to the patient? Then, whether the query or concern features prominently in the records. For example, perhaps, I think what was the example given in Parliament may not be so relevant for us, but it's the only one we have currently, is where the minister referred to, maybe there's a post-it put on the top of your records to say the patient is concerned about this issue. Then it's front and center already, right? So clearly in that kind of situation, the doctor knows the patient is concerned about this, and it needs to be addressed. Okay? Of course, in this day and age, where I think everything is electronic, perhaps in your records there's a way for you to highlight. I'm not sure, but certainly when it comes to a situation like this, bullet point number 3, whether the query or concern features prominently in the records, that kind of a statement, this one will go to court to decide what's prominently featured. Just now talk about the example of income tax law, right? How eventually the court still needs to look at certain things, how it's interpreted, how it's to be applied. So currently, because this Section 37 of the Civil Law Act is very, very new, it's only 2 weeks old. So we haven't got the benefit of any cases going to the court for the court to decide or to determine how Section 37 is to be applied. So this discussion here is very much what you can see, logically, how it's to be applied, and also what the minister has already said in Parliament. Okay? So, questions that were raised by Moman, whether there's a need to discuss the risk dialysis. Firstly, we have to consider, is this that part of standard practice to do so? Okay, in other words, cookie cutter patient. Would you discuss this for a normal, everyday patient who walks in with this particular condition, with this proposed procedure? If it is, then yes, you have to discuss the risk of dialysis. Now, what if it is this patient has got something specific, a specific condition that he or she suffers from? In this case, I think there was a discussion about whether or not I think one kidney was non-functioning. So is that a relevant factor in discussing the risk of dialysis? Again, that one is something for the peer professional to decide. Is that material information or not? Does the patient raise a concern, either at a consultation or on the records? I know there was a discussion about whether it was just a verbal discussion and also on the records. I'll deal with this a little bit further on, but that's what I need to look at, okay, in determining whether or not it's material information. Then you look at any other patient-specific circumstances that will indicate a need to discuss that risk. Okay, so I cannot give you an answer, should it have been discussed, but for a treating doctor, for a doctor who's asked to give a peer professional opinion, these are the questions you need to ask yourself. Okay, so revision, the change in the law on the issue of the giving of advice and what's considered standard of care is now determined by a peer professional opinion. Okay, it's no longer the Bolam and Bolito test that apply, neither is it the Hitchcock's 3-step test that applies anymore. But bear in mind this, the reason why I put that bracket, unless treatment already completed, is because this Act starts on 1st of July 2022. And it only applies to cases that are either ongoing, treatment ongoing, or new cases after the 1st of July 2022. Where the medical treatment has been completed already, because Acts of Parliament have no retrospective effect, unless it's criminal. Because there's no retrospective effect, it doesn't apply to cases that have already been completed. You still look at the old law, whether it's Bolam or whether it's the Hitchcock case. Okay? So moving on very, very quickly. There was this question, or rather there was this comment, what is not documented was not discussed. Is that really true? To me, I would say that documentation is vital. Okay? And why is it vital? Because when a complaint or claim comes in, I think some of you may have sat on boards before, reviewing incidences, there will be an internal review when a complaint comes in at the hospital, right? Medical board, things like that. The only way an internal review can properly take place is by going through the medical records. Okay? Because that's staring you front and center in your face. Medical records are the most important thing simply because they are what we call contemporaneous. That means they were or should have been done at the time or very soon after the events that took place. Because they're contemporaneous, they are very often objective. What I mean by this is that when you do your records, you don't know the patient is going to complain against you, right? You don't know there's going to be an outstanding claim against you. So what you write tends to be the truth. You're not doing a COA exercise at a point in time. Okay? So based on all these things, there's an internal review that's carried out to determine how to proceed as far as managing the complaint is concerned. Okay, sometimes, the complaint is made out, so we then say, okay, fine, we settle the case, we apologize to the patient, things like that. But if the records are supportive of you, then clearly the approach may be different. You may still apologize to the patient, but you may not want to settle the case because there's no wrongdoing. Okay, so that shows to you the importance of medical records. Same thing, when there's a lawsuit going to happen, records have to be provided to the patient and the lawyers. Okay, so if the information is in the records, the patient's lawyer is less likely to think there's a successful claim because he's got information there already. Expert opinion. Now, your experts base their opinion very much on the records. They don't base it on what you tell them. Okay, because when an expert is challenged in court, they're challenged on two things: the basis of their information. Number two, whether their opinion is supported by medical literature. So it's very easy for me to challenge experts to say, oh, the patient tells you this, the other side's expert. But where is it written down? Where is it documented? Okay, so it's easy to challenge people if the version of facts they rely on in arriving at the expert opinion is actually not documented. Negotiations, legal proceedings, trial, all these things I think are very obvious in the sense that, like what I said, you need to rely on records in order to determine how you negotiate. You rely on the records to determine how a trial is going to continue as well, how it proceeds. Okay? I've dealt with this point, use of records. I've also dealt with it when we talk about reviews. Now, approach of the courts in past cases. So, the question here is it true that what is not documented means it wasn't discussed? I think I've hopefully managed to show to you how important it is to have proper records, complete records kept. But there have been exceptional cases where the courts have said, oh, never mind. Even though it's not recorded, I accept that it was discussed. For example, I think we all know the Lim Lian An case, right? Where even though he did not record that certain risks were explained to the patient before the injection, the court accepted in that case that, oh, it is part of his normal practice to have discussed those risks. And so based on that, even though it's not written down and the patient swears blue in the face that it wasn't told to her, the court accepted in that case that there was actual discussion about those risks and complications. But if you have to go all the way to court and for the court to justify that to you, then I think you are asking for a bit of trouble. All right? It's always better upfront to keep proper records. Okay, that's all I have. I'm sorry it's taken so long. I think We now move to a question and answer session.
Thank you, Mr. Chung, for a very insightful talk, and it is important to our day-to-day practice. We're running a bit behind time, so perhaps I'm waiting for any question from the Q&A live session. Anyone in the audience would like to ask any question? Any question? Oh yeah, Dr. Ng from SGH.
Hi, thanks. I'm not sure if it's on, but you said what's not documented is not done. But in this day and age, there's this era of electronic medical records, and there's also a lot of times where we can use acronyms. And so what I've noticed in some of my, well, some doctors is that they use one acronym to say a certain condition, and whole paragraphs comes out. Whether it is done or not, we're not sure, but it's documented. How does that play in the real life court case then?
Yes, that is a good question. Okay, but unless when let's say the claim comes up, the complaint comes up, the doctor actually comes to us and say, actually, I did not do those things. There has to be a bit of an assumption on our part that when the doctor writes those things down, he did it. I understand that that is a common occurrence, or what you call a cut and paste job. You take something and you just paste it there. It's a question of integrity, lah. All right, that we have to assume that when the doctor puts this in his records, it was actually done. I mean, the same thing as far as patient information sheets are concerned. These days, sometimes for what I call the standard procedures, we have a whole list, right? We give it to the patient, and there's an assumption that you go through it with the patient. But that may not actually be true, right? So it's an integrity issue. Certainly, you might have patients' lawyers who are very garang. Even though it's stated there, they take you to court and they cross-examine you and say, isn't it true that actually this is a cut and paste job? Isn't it true that actually you may not have told the patient? You just have to stand your ground, because very often there's no way for the patient to get past what is on the records. Whereas if nothing is on the record, okay, the patient will swear blue in the face, the doctor did not tell me this. This is the only doctor I saw for the past 2 years to discuss about this, and I remember very clearly. If you are the doctor, when the thing comes up for trial, let's say 2 years down the road, are you going to remember specifically what you told this patient on this specific day? You probably cannot remember what you had for breakfast a week ago. How on earth did this patient, maybe 1 out of 20 each day, and 20 times 2 years? That's a heck of a lot of patience for you to then say, oh yeah, I remember very specific. This day I told the patient this. Unlikely lah. Okay. So that's why it's always better to keep proper records and then let them challenge you. Okay.
Professor Sim, question here.
Just a simple question about explaining the risks of complications in elective surgery. Some of our colleagues in UK know that they have templates in which they write down the percentage of risk of a particular complication. For example, risk of infection 5%, the risk of bleeding 6%, something like this. Is that considered something very critical in the assessment of explanation or adequacy of counseling? Because the figure may differ in different countries or expertise or even within the same operation amongst different doctors.
Okay, if we are talking about, like what I said, patient information sheets, very often my answer will be, depends on your profession to write them. Okay, what do I mean by this? Remember Bolam test, peer professional opinions? It's always based on what is the standard within your own profession. So we always encourage the various chapters, specialties to come up with your own information sheets. And what you write, whether or not you want to put percentage or not, is up to you internally to decide. And the court will accept it because this is the standard of practice for your specialization. Okay, so it depends on what you want to do. And if you tell me that, oh no, we shouldn't talk about percentages, and your specialization agrees on that, then there's no way for anybody to challenge you on that.
Okay, so if I may just ask the last question pertaining to this case. So you have a patient with solitary kidney in a teaching hospital that's working on a team-based approach. Is telling the patient that she might be operated on someone else who might be a trainee and not a full-fledged specialist on a solitary kidney considered material?
Okay. I think if you look at your medical, what is it called? ECEG. I think there's actually a provision on this where you need to tell the patient if the procedure is not going to be carried out by yourself. Okay? Now, is that material when it comes to, because that's ethical code and guidelines, right? Does it then apply when it comes to lawsuits? I would think it does. Of course, we haven't seen the case yet. Okay, so that's my caveat there. We haven't seen the case. But just like the consent taking issue, when the Hitchcock case was decided, the issues of patient autonomy, and the recognition that was required, was actually based on the Court of Appeal looking at what's in your ECG to say that, yeah, you were supposed to give certain information there, there's a recognition of patient autonomy, for them to then transplant it into lawsuits, into medical negligence cases. Okay, so identity of who is operating on you, particularly where perhaps the procedure is complicated, may be required. But of course, if the patient asks, then no need to argue. You must tell the patient. Okay, so summary, if the patient doesn't ask, maybe it's debatable. But as I said, your ECG says something already. If the patient asks, you have to tell. Okay.
I think with that we'll close this session. And if there's any question, I think maybe some of us can catch Mr. Chong outside. Okay. Thank you very much, everyone, for
Okay, thanks.
for sending me.